This episode was pre-recorded as part of a live continuing education webinar. On-demand CEUs are still available for this presentation through All CEUs. Register at allceus.com/counselor toolbox. Okay, so I'd like to welcome everybody to today's presentation on medication-assisted therapies for addiction. And if you are a mental health counselor, you don't typically work with people who are in active addiction, that's cool. If you are working with someone who is in recovery from addiction or on medication-assisted therapies, it's helpful to know what meds they might be on and how that might be impacting their mood, as well as some of the contraindications you might want to be aware of, so you know when your patient is getting into a position where they might be in jeopardy of harming themselves. We're going to discuss the purpose of long-term pharmacotherapy. And when we talk about long-term, it's not necessarily forever and always, but we're really looking at several years as opposed to 6 months. We'll identify pharmacotherapies for smoking, alcohol, and opioids for the most part. We're also going to talk about some of those other drugs that don't have medication-assisted therapies identified for them. So why do we use them? In early recovery, we want to help people reduce cravings when possible. And medication-assisted therapies that are so labeled are designed to assist patients in not having as many cravings. So the medication-assisted therapies can help reduce their desire, their compulsion, their obsession to go back out and use in order to feel that feeling again. It provides increased self-efficacy and a greater sense of control when clients can go in and say, all right, I'm taking this, it's going to help me not have cravings. Well, we know part of it's going to be placebo effect. That's okay. I don't care where the effect's coming from. If it's a positive effect, I'm pretty darn happy. So we want to look at what is this helping the client with. And obviously, if you're giving somebody a medication that doesn't do anything at all, or a sugar pill or something, you're probably going to have different results. So I don't want to trick the clients, but I do want to help them see ways that the medications they're taking might help them in early recovery. Medication-assisted therapy can help reduce anxiety in a lot of our clients. Because a lot of clients come in and they've relapsed before and they're trying it again and they're afraid they're going to fail again, or they haven't relapsed but they're going to go to jail if they relapse, or they're going to lose their kids. There's a lot at stake on this. So there's a lot of anxiety about, if I relapse, how am I going to deal with the feelings and the cravings and the yada 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 so I don't relapse, and they just focus on all of the what ifs. Medication-assisted therapy can help patients have something to focus on, to say, okay, I've got this tool. Now, we're not necessarily talking about a tool forever, but we're talking about a tool to help them climb the mountain. Think about those little poles that people use when they're climbing the mountain. That's kind of what we're thinking about with medication-assisted therapy. It's helping people maintain their footing while they're climbing to the apex of recovery, if you will. It also may improve depressive symptoms by enhancing hope and a sense of empowerment. Remember, depression goes with hopelessness and helplessness. So if we can encourage them to focus on the fact, well, this medication-assisted therapy may help you not have the cravings. It may make it easier to get through this early recovery period so you can master the skills and tools you need to live a sober lifestyle. That gives me hope when I say it, so I'm hoping it'll give the clients hope when they hear it. And it gives them a sense of empowerment because it says, you have control over this. We're giving you some tools. We're giving you those little walking poles to help you keep going forward. It's not going to be easy. We're not saying it's going to be easy, but we're going to try to help bolster you along the way. And certain medication-assisted therapies have pharmacological effects that will help alleviate depression and anxiety. So that's a nice sort of side effect, if you want to look at it that way. If you're using it to reduce cravings, but it also is an antidepressant, well, then bonus. We want to reduce co-occurring issues. We know that people who come into detox, if you've worked in a detox facility or even in a crisis stabilization unit, and a little story here that will ring true with a couple of you. The last place I worked, well, a couple places, it was a big facility, and we had a crisis stabilization unit and we had a detox unit. Now, I was over the detox unit, and we would have clients come in and they would be in crisis. They may be actively psychotic, but they would also be stoned out of their minds. So the crisis unit didn't want them because they're like, well, we can't handle monitoring detox. And we didn't want to take them because we didn't have the staffing to monitor and handle the psychoses. We didn't have a psychiatrist on our facility. So every time one of those clients would come in, we'd end up with this hot potato, and they'd be calling the supervisors at home going, who gets them? And really it would end up with an evaluation of what is that person's psychiatric stability and how can we cooperate. Thankfully, we were on the same campus. So if the person had to stay over at the crisis stabilization unit, then our nurse would go over and do the periodic checks to make sure that they were doing okay, do the CWAS, whatever they needed to do. If the person was stable enough, or they could get them to the point where they weren't actively psychotic and a danger to themselves or others, then they could come over to the detox unit where my staff would monitor their detox protocol. So it was, unfortunately, when you've got people with co-occurring issues, it's really a struggle. And most people in early recovery have co-occurring issues. Now, they may not be floridly psychotic, but they are probably going to have some pretty significant depression or anxiety. I mean, just because of the neurotransmitter imbalance. Remember, we've talked before about how when addictive behaviors are used, the brain is flooded with whatever that chemical is. And that chemical recedes, if you want to think about ebb and flow, that chemical recedes just as quickly, pretty much, as it went in, and a little bit different than that, but a lot quicker than the body can catch up. So it goes away, and there's not that counterbalancing chemical in the right levels to help the person feel normal. And you're burning through, if you will, a lot more neurotransmitters. So there's going to be neurotransmitter imbalance. People are going to feel crappy. And when they feel discomfort, and I use that term very generally because the discomfort they're feeling is palpable. I mean, it is really crushing sometimes, anxiety and depression. They need that to go away. They're like, I cannot survive feeling this way. So what is the response? A lot of times, go out and use again. So in early recovery, we really need to help people get to the point where their neurotransmitters are stabilized enough where they're not feeling like they have to escape, where they're not feeling like they can't breathe because of the anxiety and the depression, and they're not craving the drug, which is a whole different ballgame. But this is what we're heading towards. We need to identify and address vulnerabilities. And, medication-assisted therapy, giving them medication or them taking medication, however you want to look at it, is one aspect. Just giving them a pill is not going to fix everything. It helps them stabilize so they have the energy and the clear-headedness, hopefully, to participate in their recovery process. And then we start identifying and addressing their vulnerabilities. If they're homeless, if they're not eating enough, if they've got hepatitis C, if they've got anything else going on that might be contributing to their stress, their pain, and their neurotransmitter imbalance. So we help them improve overall health, education, nutrition, energy, help them maintain abstinence. Most of the time, what we're talking about here, most of the drugs, the drugs we're talking about, people can abstain from. You're not going to die if you don't have cocaine. It's not like telling somebody they can't ever have food again. So we want to look at this and go, during this period of early recovery, how can we help you maintain abstinence so your body can rest, recover, and rebalance? And that's kind of a hot button topic, whether you say you've got to abstain forever or you approach it from during this period of early recovery. I have found, and from a motivational perspective, I have found that in early recovery, there's still a little bit of ambivalence. Clients can't imagine going the rest of their life without cocaine, without a drink, without this or that. And if I start talking about forever, it freaks them out. So we talk about how can you maintain abstinence right now? Because you're here, what are your goals, and how can I help you achieve those goals? One of them is to help you reduce the cravings, improve your mood, improve your health, and let's see where you want to go from there. If a relapse occurs, medication-assisted therapy often reduces the intensity of the relapse. So that's something to kind of bear in mind. Most drugs, with the exception of some of the nicotine drugs, which are very dangerous if you smoke while you're using them, will either have a negative effect and make you feel sick, but they're not like life-threatening, or they've already blocked some of the receptors. So when you use the street drug, you don't get the same high, and it's just like, whatever. Part of a comprehensive plan that addresses recovery involves us helping people deal with their emotional, cognitive, physical, social, occupational, and environmental issues. So we're going to look at that. But remember, people are not going to be able to maintain housing if they're spending all their money on dope. People are not going to maintain a job if they can't get there because they're too hungover or strung out. So medication-assisted therapy plays a critical, pivotal role in early recovery, helping people start reestablishing a new drug-free life. It's not a substitute for counseling. We're not saying give them a pill, it's going to make everything better, and they can go on their merry way. And that is a misconception a lot of people have about methadone clinics, and we'll talk about methadone a lot towards the end of the presentation. But it's important that medication-assisted therapy is a tool. You have that person climbing the mountain, and okay, they know how to use these walking sticks, and there's probably a different word for them, but we'll call them walking sticks. But they need to know how to adjust their breathing when the oxygen starts to get thinner. They need to know how to handle it if all of a sudden a snowstorm comes up. They need to know how to handle it if some other obstacle comes in their way. That's what counseling does. Counseling helps educate people about how to get to the top of the mountain and stay there and thrive instead of, falling back down. The co-occurring model of addiction. Now, I want you to just kind of remember this as we're talking. It says that co-occurring disorders are the expectation. The person may not have been depressed, anxious, whatever, before they started using. They may not have even been symptomatic for bipolar or schizophrenia, but the stress of the addictive behaviors and the stress on their body can trigger the psychosis or the bipolar disorder to kind of show its head. So it's important to understand that people may not have initially started out self-medicating. They may have started out using just recreationally, and then something happened and they used a little bit more. And as they used more, their brain chemicals got progressively out of whack, and then they started needing to use to feel normal. So by the time they get into active addiction, they've either created a mental health issue, neurotransmitter imbalance, or, that one that was still there, they're self-medicating. Either way, in early recovery, I haven't ever met anyone who didn't have some level of co-occurring issues, and that's okay, but they need to understand how that mood issue impacts or plays into the recovery process. Relapse begins when thoughts, urges, or behaviors return to that addicted mindset. So again, we need to look at if somebody starts relapsing, their depression starts increasing again, those depressive thoughts start increasing again, then those thoughts of suicidality and wanting to escape and making it stop are going to come back in, and we see an addiction relapse after that. Addictive behaviors were learned as a way to stop distress, and learned behaviors cannot be unlearned. So some people talk about a disease concept. I really talk about learned behaviors. Think about a salesman. A salesman may be great at selling, let's say, cars. And then they decide one day, you know what? I don't want to sell cars anymore. This isn't fulfilling. I want to be a plumber. And they learn how to be a plumber, and they're good at that. But then all of a sudden, something happens and they can't be a plumber anymore. The plumbing is not paying their bills, but they know they can go back and be a good salesman. This is kind of what we're talking about with addictive behaviors. When the good coping skills, when the healthy coping skills, when the sober way of life quits working for some reason, one option, it's not the only option, but one option is to go back to those addictive behaviors that made the pain stop. We want to help people learn alternate behaviors and their consequences, which are more rewarding than the addictive behaviors and their consequences. Addictive behaviors may have really awesome short-term consequences, makes the pain stop, but in the long term, not so much. It's more of punishment than positive reward. Our recovery behaviors in the short term may not feel so great. Distress tolerance does not feel near as good as, numbing with opiates or something else. But does it help the person achieve their long-term goals? So when do we use drugs? Well, there is no pharmacotherapy for most abused drugs. Stimulants, which includes amphetamines and cocaine, and Adderall and all those. Hallucinogens, inhalants, and marijuana. So, and some of these, they talk about having more psychological addictive behaviors than actual physiological addiction. Either way, if they're addicted, if they have withdrawal symptoms, we're going to have to address it at some point. So what I look at is what are the functions of these different behaviors? Since there's no drug out there that's specifically FDA labeled to address cravings, I say, well, why would the person use it? Let me see if I can get a clue as to their neurotransmitter imbalance. And one of them is, we'll start with stimulants and cocaine. The cypramine is actually a tricyclic antidepressant, and it was brought to my attention before this presentation. And it's actually a norepinephrine reuptake inhibitor with very little effect on serotonin. So let's think about this. Cocaine is a stimulant. All right, we got that. Norepinephrine is our get up and go and focus neurochemical, among others, and glutamate and stuff. But if we increase the level of norepinephrine, we're increasing the energy level, the availability of focus and motivation, which is a little bit similar to what cocaine does. So, and when we look at people who use cocaine, what are they wanting? They're wanting energy. They're wanting to feel good. They're wanting more dopamine. And, some drugs, some pharmacological drugs can help them feel a little bit better. They can take the edge off that feeling flat and unfocused and unmotivated, and I just can't do this. There was a study that was done, and let me see if I can find it, in Addiction Science and Clinical Practice in 2003 that showed that desipramine was actually somewhat effective at helping people in the study maintain drug-free urines. So that was kind of an interesting, that was Addiction Science and Clinical Practice in 2003. That is not on your quiz, just point of interest. So when you're dealing with stimulants, we know you're dealing with somebody who is trying to rev themselves up, which means they probably feel bleh, and they either feel bleh, unmotivated and depressed, or bleh, no happiness and the dopamine is low. So we want to look at, are there pharmacological interventions that a psychiatrist could help them with that might help rebalance some of that or help them address some of those symptoms of apathy or lack of pleasure. Lack of pleasure kind of is part and parcel of depression. So generally, your docs are going to look at antidepressants first. Antidepressants, and I'm going to go through the big five just because those are the ones that most people, I think five. Zoloft tends to be pretty neutral as far as energy, but it has shown a lot of effects for helping people with compulsive behaviors, especially bulimia and compulsive gambling. So Zoloft is out there. When we look at Prozac, tends to be much more stimulating and can increase anxiety levels. But if you've got someone who's looking for more energy, Prozac might help them, as are some other drugs. I'm just going over the older ones that we're talking about. Paxil, on the other hand, tends to slow people way down. It helps with anxiety, so does Zoloft. But Paxil tends to make people sleepier. So a lot of people who take Paxil take it at night. If you've got a patient who's really looking to wake up and get some motivation, obviously it's between them and their doc, but my experience over 20 years has told me that that patient is not going to be very happy on Paxil. So I guess those are the big three that I really wanted to talk about right now. Now, hallucinogens. You don't really think of those as drugs of abuse. You don't have somebody coming into detox for being addicted to LSD. But they are out there. Psychedelics, and I learned this doing this presentation. There are 3 different types of hallucinogens. Psychedelics, which act on the 5-HT2A receptor. If you remember from Tuesday's presentation, 5-HT is your serotonin receptor family, and there are, I believe, 18 different types of serotonin receptors. 5-HT2A is just one of those. But your antidepressants work on different 5-HT receptors. So each antidepressant may not work on 5-HT2A. So if you've got somebody who's using psychedelics, and we're talking about your LSD, PCP, they're using them often to get that state of, quote, empathic well-being. They just kind of love everybody and the world is good and we're going to hold hands and sing Kumbaya. I would want to say, what is it when they're not on that? What are they feeling when they're not on that they really need a drug to help feel empathy and compassion and love for themselves and other people? I'm hearing anger, maybe anxiety, maybe some depression, but that would be talking with the client to figure out what's going on. But anyway, 5-HT2A we know is a serotonin receptor, so we want to look at a drug that's going to target 5-HT2A. Your dissociatives reduce your glutamate level. Now remember, glutamate is the one that's secreted during the fight or flight response. So your dissociatives are probably going to be in people who have higher levels of anxiety. They have altered pain perception, and it's a depressant. It's going to make them slow down. Respiration slows down, that sort of thing. But again, you're having somebody slow down instead of speed up. Ketamine. We talked about that on Tuesday, but ketamine is a huge hallucinogen that is used to help people calm down in certain emergency situations. It's actually a horse tranquilizer. But dextromethorphan is a big one that the youth of today are abusing. And dextromethorphan can be bought over the counter. It's a cough syrup. You're probably familiar with it. But if you get it pure and not mixed with guaifenesin or one of those other things, the youth are taking the pure dextromethorphan and using it rectally in order to get high. So being aware that that's an increasing problem. I digress. So if somebody's using a dissociative hallucinogen, I might look at anxiety issues and try to figure out what's going on there. Deliriants, Benadryl and Dramamine. Now, deliriants are really dangerous because the level between recreational use and lethal is really, really, really small, and it's really easy to kill yourself. Okay, that's fine, whatever. Warning all over. But the deliriants reduce acetylcholine. And we know that acetylcholine is involved a lot in schizophrenia and powerful dreaming and active mind. And there's a reciprocal relationship between acetylcholine and serotonin. See, you knew I was going to get somewhere that made sense. As acetylcholine goes up, serotonin goes down. So if somebody is abusing acetylcholine, we might look and say, I wonder what's going on. Maybe their levels of serotonin are too high. Maybe they've got some anxiety going on. What is the benefit of this for them besides just, the overall feeling. But there are a lot of medications that they can look at. The selective norepinephrine reuptake inhibitors would be kind of tops on my list, but again, that would be between them and their psychiatrist. The take-home message is hallucinogens can be used recreationally, but if you've got someone who's addicted to them, then there's some other reason, some other thing that is keeping them coming back besides just, a feeling, because they're foregoing other activities in their life in order to use this substance. It's almost intolerable to be without it. Your inhalants are depressants. So just like alcohol can be a depressant or is a depressant, if somebody's using inhalants or alcohol, I tend to look for high levels of anxiety and see what's going on there, where the inhalants actually make them feel better. And interestingly, marijuana increases dopamine, which helps it be relaxing or pain relieving. But I've heard a lot of people who've used marijuana, really potent marijuana, or the new resin dots that have come out that have had really, really bad trips. Spice was just new when I was leaving residential, or not super new, but it was newish. And I would regularly have clients go out on work phase and come back in. They'd use Spice, and they're like, well, it's not going to show up on a drug test, and it's legal, so I can use it, because that's the way the addictive mind thinks. And on 3 occasions I can think of in the course of a year, we had to call the ambulance out because the person's heart rate was at like 200, literally 200, and they were laying on their bed and they felt like they couldn't move. Their arms and legs were so heavy they felt paralyzed. So marijuana is not always, and obviously that was Spice. They were using the synthetic THC, but the side effects can differ between people. We want to look at why they're using it. Oops. Factors to consider when you're looking at, do we consider pharmacotherapy? Cost. Now, my little soapbox here. If a patient needs medication, many places that make the drugs will give out patient assistance programs, or give out vouchers through their patient assistance programs. AstraZeneca has a really good patient assistance program, Eli Lilly. So you find the manufacturer of the drug, you go online and you Google that company's name plus patient assistance program. It's the easiest way to do it. And then it'll bring you to the page or close to the page for that pharmaceutical company that has the patient assistance program forms on it. The forms are usually 1 page. The doc fills it out, faxes it in, they make a determination, and yada, yada. Not every drug is covered on patient assistance programs, but a lot are. And there's also a lot of drugs, the generics especially, that are available on formularies, the $4 prescriptions or whatever, through different pharmacies. So in large part, for many medications, there is a way to get them affordably, even if your patient doesn't have access to insurance for their prescriptions. Another thing to consider is availability. Can this drug be gotten easily? Methadone is a perfect example of that. Methadone clinics are not on every street corner. And so if you're going to have your client start a methadone program, they're going to have to go every single day, 7 days a week, in order to get their meds, because they're not allowed to take home any. So do you want them driving an hour and a half there and an hour and a half back every single morning in order to get dosed? And are they going to do that? Are they going to stay compliant? You want to consider the side effects. If this person takes this medication, what are the side effects, and are those acceptable side effects in that person's purview? We want to look at barriers. Workplace drug testing. If they're working somewhere that prohibits the use of methadone, and then even if they're on prescription methadone, it would show up in a drug test and they may lose their job. There is some argument about whether that's legal, but let's be realistic here. The time it would take to fight that out in court would be, not good. What other meds are they taking? There are a lot of medication-assisted therapies that don't play nice with other medications, so we have to know that. A client cannot be on buprenorphine or methadone and be taking benzos. So, if they're going to continue to take their benzodiazepines, they're going to not be eligible to take some others. And incarceration. With methadone, with Suboxone, with buprenorphine, with any of these meds, actually, I've found in the criminal justice system, clients generally in the 3 states that I've worked, and I'm not going to say this is everywhere, when they go into jail, they are taken off all medication. And the only way they get put back on medication is if they are not manageable in the population. Now, I could go off on a whole tangent about that, and I will refrain for right now. But that means if they are on medication-assisted therapies for addictions, the thought is going to be, well, they can't get the substance in here. They don't need these. Cut them off cold turkey. And that can get really ugly if they're on methadone or anything else. And if they're incarcerated, they're not going to be able to get the medications if you happen to work in a jail. And finally, what is their motivation? Are they willing to actually do the work so the medication-assisted therapy can be successful? Because it only does part of it. Medication-assisted therapy is only the walking sticks. They have to use their own feet to move up the hill. So we need to know, are you willing to do the counseling to address the issues and make behavior and lifestyle